this is what I think a lot of us struggle with, is we're sort of comfortable with chemo, the patient's comfortable with chemo, they get to this place, we have this twinkle in the eye that maybe, just maybe, it'll respond, but we're leaving often OS things on the table. And of course, all of us also have the other incentive that we're driven by, and that is clinical trial accrual, right? And so many of our clinical trials don't require this line of therapy, and we have other things to do. So maybe start us off as world's expert in clinical research. So where are we looking for clinical trials in patients in colon cancer?
What do you mean, where?
Which patient is the most appropriate for ready for a clinical trial?
I would say probably almost any patient with a good PS of 0 to 1 and good laboratory values. And
in the refractory setting?
Regardless of refractory setting, yes. And the willingness to participate in a trial and make the effort to come on a regular basis and be adherent. Because we need patients to participate in clinical trials. That's how we make the impact on advancing the field.
Yeah. Why don't we have a frontline clinical trial?
I was going to ask about.
I was looking at you.
What about window trials? They do it in pediatrics
Yeah.
in a patient with, asymptomatic metastatic disease that you see.
Perfect place.
What about using a window trial, moving a biologic from 23rd line therapy up to first line therapy?
I invite you to our poster of what we call the Alexandria trial of TAS-102 and Bev in the maintenance. For what the heck? It's something to do in that window. Not that exciting, but it's a switch in a way, right? So we've been really struggling with front line.
Yes.
Second line's really hard to accrue to, in my opinion, because they keep coming from different angles. So this space has been the most successful space, this sort of
And also
refractory
lines
setting.
of therapy is kind of an antiquated term.
Yeah.
When you use maintenance therapy, what is it? Did you stop because of toxicity, or did you stop because of progression, or you just stopped? So those are very different patients.
And is there a role here, let's say I've got this patient, good PS, for now doing that repeat biopsy and maybe doing another profile and seeing if they fit into match or taper? Is this that patient you want to be doing that in? Reasonable?
Yes,
all around?
definitely.
So that's the thought, and now with these trials we'll have an outlet for those patients going forward. So a year gone by, new ASCO. What's really important for every community oncologist needs to know around colorectal cancer that's new?
Well, I think the biggest story at ASCO is the left versus right, and its potential implication of prognosis and possibly selection of agents coupled with chemotherapy. So I think pay close attention to the side of the tumor.
Cathy, hot new drugs, other new approaches that we need to be looking at?
I would say there's obviously a lot of interesting early developments, but nothing that's really a home run right now. I think probably the greatest interest is the sidedness.
Yeah. Tara, thoughts, closing?
Yeah, the sidedness is huge, but also really just encourage patients to enroll in a trial. That's the be all and end all.
When we have them.
When we have them.
It's always good. Dan, you've been at this a long time. Where are we in colon cancer? Are you pleased with where we've gotten?
Yeah, because now it's confusing. And that's the good, being confused is good, but I think probably the most exciting next step is going to be the checkpoint inhibitors.
Yeah.
And we didn't talk much about it, but checkpoint inhibitors work when you have a lot of mutations. So melanoma, non-small cell lung cancer, bladder cancer, most recently, and only MSI-high GI tumors. And the work from Hopkins, from Dunlea, is amazing. Yeah, showing third-line pancreas Lynch patients with response rates in the double digits. I think there's no chance that those drugs are not going to be approved in some subset of colon cancer. And if it's only 5%, because MSI-high primary tumors don't relapse as often. Good, bad, that we don't have very many metastatic MSI-high patients, but it's as high as ALK for crizotinib. It's as high as a lot of other mutations, so I'm pretty excited about that.
Yeah, I want to thank all of you all for joining me. It really is an exciting and confusing time. So we want to take good care of our patients. Our patients are living longer, and I hope this session has been useful to you out there as we've moved forward and advancing the ball in the treatment of metastatic colon cancer. So on behalf of OncLive and all of these really smart people up here, John Marshall, thank you for joining us.